Hello, good morning. I have prepared this video for you to teach you about EKG rhythm and readings, a sample mock code video so that you know what to expect in a mock code and how to delegate responsibilities, a crash cart orientation so you know where to get things during a mock code, and crash cart emergency medications and how to put it together. So have fun. This is EKG 101. A 12-lead EKG records 12 different views of the heart using a series of electrodes placed on the patient's limbs and chest. This is 1, 2, 3, 4, 5, 6 on the chest. Then right arm, left arm, right leg, and left leg. There's 10 leads you have to put, but it's a 12-lead EKG. These are the components of an EKG waveform. The P wave represents atrial depolarization or conduction of an electrical impulse through the atria. The PR interval tracks the impulse from the atria through the AV node. The QRS complex represents the repolarization of an impulse conduction through the ventricles, after which the ventricles contract and blood is ejected and pumped through the arteries, creating a pulse. The ST segment represents the end, right here, the end of ventricular depolarization and start of ventricular repolarization. To measure the P to P intervals, if it's consistent, then the rhythm is regular. Then you calculate the rate by obtaining a 6-second strip, count the number of P waves, then multiply by a rate by 10 to get the rate per minute. And then you determine if a P wave is present for every QRS complex. Measure the PR interval, count the small squares between the start of the P wave and the start of the QRS complex, multiply by 0.04 seconds. The normal is 0.12 to 0.2 seconds. The QRS duration, a normal is 0.06 to 0.12 seconds, and then the QT interval normal is 0.36 to 0.44 seconds. Recognizing normal sinus rhythm. This is a normal sinus rhythm. The atrial is regular and the ventricular beat is regular. The rate is 60 to 100 beats per minute. The P wave is normal in shape, it's round and smooth. One P wave for every QRS complex. The PR interval is 0.12 to 0.2 seconds. The QRS complex is 0.06 to 0.1 seconds, and the T wave is normal in shape, which is upright and rounded. Sinus arrhythmias, the rate is within normal limits. However, it increases during inspiration. There's 2-3 beats here, and decreases during expiration. There's only 1 beat. The PR interval varies. The QRS complex is preceded by the P wave. The QT interval may vary slightly. The rhythm is irregular and corresponds to the respiratory cycle. This can be caused by vagal activity, inferior wall, myocardial infarction, or drugs. P to P interval and R to R interval can be shorter during inspiration and longer during expiration. If the patient is taking digoxin, the treatment would be to notify the doctor for possible digoxin toxicity. However, if it's asymptomatic, the treatment is usually not needed. If it is induced by morphine, then notify the doctor. You will decide whether to continue giving the drugs. This is sinus bradycardia, is very slow, less than 60 beats per minute. The rhythm is regular. Impulses originate from the sinus node. The P wave is normal. PR interval, the QRS, and the T wave are normal. The QT interval is within normal limits or is longer. These are the causes, can be cardiomyopathy, heart block, etc. There will be a poster in the simulation lab, so you don't need to know all of these causes. Just know that that's what they are. There's usually no treatment if it is asymptomatic and the patient has stable vital signs. Review the patient's drug regimen for drugs that depress the SA node. If the patient has symptoms of reduced cardiac output, identify and correct the underlying cause and notify the doctor. And prepare the patient for treatment as needed. For example, follow the ACLS bradycardia algorithms. This is sinus tachycardia. The rate is above 100 beats per minute in adults. The rhythm is regular, P wave is normal, and it may be superimposed on preceding T wave as heart rate increases. The PR interval, QRS complex, and T wave is normal. The QT interval shortens, and these are the causes. It can be normal response to exercise, fever, pain, stress, and strong emotions. No treatment is needed if asymptomatic, but we have to correct the underlying cause. If the patient has cardiac ischemia, give drugs to slow the heart rate. Notify the doctor right away if sinus tachycardia arises suddenly after a myocardial infarct. It may signal an extension of the infarct. Provide a calm environment. This is sinus arrest. It is episodic failure in automaticity or impulse formation of the SA node and lack of atrial stimulation. Normal sinus rhythm is maintained. However, there's occasional prolonged failure of the SA node to initiate impulse. The PQRST complexes are missing. The length of frequency of pause may result in bradycardia. There is absent in P wave sometimes, and PR interval is normal when the heartbeat is present. Also, the QRS complex is normal, but is absent during the arrest. There's no treatment needed if asymptomatic, but we have to discontinue the drugs that affect the SA node discharge or conduction. You have to protect the patient from the risk of injury, such as a fall from a syncopal episode. The goal is adequate cardiac output and perfusion. Delayed or this is the second degree and third degree block. These are the causes, conditions that affect the atrial wall around the SA node, including fibrosis, etc. No treatment is needed if asymptomatic, but if symptoms develop, you alleviate them and correct the underlying issues. If arrhythmia results from a chronic disorder, treatment may include digoxin and other drugs, or a radio frequency ablation. Anticoagulant is needed for atrial fibrillation because of the risk of thromboembolic complications. This is PAC, this rhythm. Impulses originate in the atria outside the SA node. It is irregular, as you can see, and the rate is around 90 beats per minute. The P wave is abnormal or absent. T wave is also abnormal with some embedded P waves. Maybe a single beat, or bigeminal, which is every other beat, or trigeminal, which is every third beat. Or it could be couplets, which are just pairs. These are the causes. And again, there's no treatment needed if asymptomatic. However, if it's symptomatic, you have to eliminate trigger factors such as caffeine or alcohol. May treat with drugs. If the patient has ischemic or valvular heart disease, you have to monitor for signs and symptoms of heart failure, electrolyte imbalances, and development of more severe atrial arrhythmias. This is atrial tachycardia. SVTs is when the impulses originate above the ventricles. So this atrial heart rate is about 150 to 250 beats per minute. Rhythm is regular. You can't see the P waves. The PR interval is about 0.12 second. The QRS complex is 0.1 second. The TV interval is distorted by the P wave. QT interval is about 0.2 seconds. It can be caused by ditch toxicity, which is the most common, and other things which would be on the poster board. The treatment is towards eliminating the cause and decreasing the ventricular rate. You have to inquire about digoxin use and assess for toxicity, teach the patient how to do the Valsalva maneuver to slow the heart rate down, or do the carotid sinus massage. Drug therapy can be used, but if all else fails, you have to do a synchronized electrical cardioversion. If arrhythmia is related to Wolff-Parkinson-White syndrome, they have to do a catheter ablation to control recurrent episodes of atrial tachycardia. This is atrial flutter. The rate is 250 to 350 beats per minute. The atrial rhythm is regular. Ventricular rhythm is irregular. P wave is about classic and sawtooth appearance. Can't measure PR interval. The QRS complex is about 0.08 seconds. The T wave and the QT interval, you can't identify it, and the QT interval is 0.2 seconds. It can be caused by conditions that enlarge atrial tissue and elevate atrial pressures. These are other causes. The treatment depends on the patient's cardiac function, if it's pre-excitation syndromes and the duration of the arrhythmia, if the patient is hemodynamically stable and the atrial flutter has lasted less than 48 hours, you have to do synchronized electrical cardioversion or countershock as soon as possible. Anticoagulation therapy should be given before and after cardioversion, and stay alert to the effects of digoxin, which depresses the SA node. Recurrent atrial flutter may be treated with ablation therapy. This is atrial fibrillation. It's chaotic, asynchronous. The electrical activity is in the atrial tissue. It results from firing of multiple impulses from numerous ectopic pacemakers in the atria. It has no P waves, and it's a regular ventricular response. It could be preceded by PACs, premature atrial contractions. The atrial rhythm is indiscernible. Ventricular beat is about 130 beats per minute. PR interval is also indiscernible, and the QRS complex is about 0.08 seconds. It can be caused by MI, atrial septal defect, and other things. The treatment includes drug therapy to control ventricular response, or a combination of electrical cardioversion and drug therapy. If the patient is hemodynamically unstable, we do unsynchronized. We have to do synchronized electrical cardioversion immediately. It's most successful if done within 48 hours after atrial fibrillation starts. Symptomatic atrial fibrillation that doesn't respond to standard treatment may be treated with radiofrequency ablation or surgical removal of the left atrial appendage. This is PVCs, ectopic beats that originate in the ventricles and occur earlier than expected. It may occur singly or in pairs, which are called couplets, triplets, or clusters. The rhythm is irregular. It's about 120 beats. P wave is present right here. P wave is absent with PVCs, I was going to say, but present with other QRS complex. The PR interval is normal. QRS complex with bizarre configuration and duration. The T wave is normal but in opposite direction from QRS complex with PVCs. It can be caused by these enhanced automaticity, etc. If the patient is asymptomatic and doesn't have heart disease, it won't need treatment. If the patient is symptomatic or a dangerous form of PVC is present, then the treatment depends on the cause of the problem. This is VTAC, or ventricular tachycardia, when 3 or more PVCs in a row with a ventricular rate above 100 beats per minute. It may progress quickly to VFib, or ventricular fibrillation, and cardiovascular collapse because of decreased ventricular filling time and cardiac output. Rhythm is regular, P wave is absent, PR interval is unmeasurable, QRS complex is wide and bizarre, and T wave is in the opposite direction of the QRS complex. QT interval is also unmeasurable, and it can be caused by drugs and myocardial ischemia, etc. Treatment for VTAC: if patient has pulseless VTAC, is treated as those with VFib and require immediate defibrillation. If the patient is unstable and has a pulse, you perform immediate synchronized cardioversion. A patient with chronic recurrent episodes of VTAC who's unresponsive to drug therapy may need an implanted cardioverter defibrillator. Ventricular fibrillation: a chaotic, disorganized pattern of electric impulses all over the place from multiple ectopic pacemakers in the ventricles. There's no effective ventricular mechanical activity or contractions. The rhythm is chaotic. The rate is undetermined. The P wave is absent. PR interval you can't measure. QRS complex and T waves you can't see. It's caused by acid-base imbalance and coronary artery disease, drug toxicity, etc. The treatment for VFib is to start CPR to preserve the oxygen supply to the patient's brain and other vital organs until the defibrillator arrives and is fully charged. Defibrillate the patient immediately with 360 joules, administer epinephrine or vasopressin, follow the ACLS protocol for giving an anti-arrhythmic, and instruct the patient's family how to perform CPR for discharge, because they might need it. CPR 101. For CPR quality, push hard, at least 2 inches, and fast, 100 to 120 minutes. Minimize interruptions in compressions. You change compressor every 2 minutes or sooner if fatigued. It's a 30-to-2 compression ventilation ratio if there's no advanced airway. Pediatric CPR, you push hard, greater than or equal to 1/3 of the anterior-posterior diameter of the chest, and fast, 100 to 120 beats per minute. Make sure you allow complete chest recoil. Minimize interruptions in compressions. Change compressor every 2 minutes. 15-to-2 compression ventilation ratio if no advanced airway. For ventilation, you avoid excessive ventilation, only enough breath to see a chest rise. If there are no spontaneous breaths, consider advanced airway. Once an advanced airway is in place, give 1 breath every 6 seconds or 10 breaths per minute with continuous chest compressions. You don't need to the ratio. And these are the reversible causes, the H's and T's. And that's it. Now we're going to watch a mock code video so that you know what to expect.
Hey Shelby, I saw your call light going off. How can I help you?
My chest is just feeling really tight and I really can't breathe.
Let me listen to your lungs really quick.
I tried using my inhaler, it won't work.
Can I get some help in here, please?
Hey, what seems to be a problem?
Shelby was admitted to our floor yesterday after surgery. She's complaining of shortness of breath. Her heart rate is 134, respirations at 22. No known cardiac issues, but she does have a history of asthma.
Okay, I'm gonna go ahead and call Pickering. Can you get Estelle in the crash cart?
Okay. Hey Estelle, can you grab a crash cart, please?
Alright, we'll do. Got the card. Okay. She has no pulse. Estelle, can you get over here and start compressions?
Okay.
Okay.
I'll document it.
Good idea.
I'm drawing up 1 milligram of epi. Compression started.
I'll go ahead and document it.
I'm the RT. Does she have any history of any respiratory issues?
She does have a history of asthma. Her pulse was at 134 and her respirations were at 22. And addition went into pulse and speed tack.
Okay, got it.
I have 1 milligram of epi drawn up.
Okay, go ahead and give 1 milligram of epi. Thank you.
1 milligram of epi given.
First round of epi given at 0800.
Amy, can you go ahead and hang a liter of normal saline?
I'll get the normal saline up now.
Thank you.
One liter of normal saline hung.
It's been 2 minutes, guys. Let's get a pulse check and switch compressors.
Go ahead and begin charging.
Charging.
Yep, no pulse. Go ahead and defibrillate at 150 joules.
Clear. Shocking. Shock delivered.
All right, team, what do we have?
This is my patient. She was admitted yesterday after surgery. She's now in pulse with speed tack and has been unresponsive for 2 minutes. Her O2 sat is currently at 96%.
Okay, what have we given so far?
We've given 1 round of epi, hung a liter of saline, and defibbed once at 150 joules.
Amy, could you please pull up 300 milligrams of amiodarone?
300 milligrams of amiodarone being drawn up.
Thank you. 30. All right. Good compressions, Ryan. Thanks.
300 milligrams of amiodarone given.
300 milligrams of amiodarone given. That's the first dose. Let's switch compressors again. It's been 2 minutes.
All right, let's also check for a pulse.
Still no pulse.
Charging.
All right, let's get ready to defibrillate at 200 joules, please.
I'm clear. You're clear. We're all clear.
Clear.
Shocking. Shock delivered.
All right. All right, Amy, could you also pull up a milligram of epi, please?
1 milligram of epi drawn up.
Thank you.
1 milligram of epi given.
Second round of epi given at 0804. It's been 2 minutes. Let's check the pulse again and switch compressors.
I've got a pulse. Can I get someone to confirm it?
All right, I have a pulse. Good job, team. Let's initiate hypothermia protocol.
Lastly, we are going to orient you on a crash cart and emergency medications and how to put it together.
The goal of this video is to orient you to the multifunctional crash cart that you'll be using during your simulation education encounter. This multifunctional cart can be used for infant, pediatric, and adult situations. All items in the cart are available for use. Your specific scenario will dictate which items will be needed. ACLS, PALS, and CPR algorithm guide cards are available for your use. A medication dosage guide and labels are also available. A defibrillator is available for use during your scenario. For in-depth instructions about how to use it, please view the defibrillator instructional video. A sharps container is located on top of the crash cart. Please use it when you need to dispose of any needles or sharp instruments. A scribe sheet is also available on the cart. Please use this to record specific patient information, including vital signs, medications, and other important patient information. A blood glucose meter is also available. Please simulate pricking the mannequin's finger and then view the meter for the results. Infant, pediatric, and adult ambu bags will be hanging on the cart. When appropriate, attach the tubing to the Christmas tree of the O2 flow meter. A stethoscope is also available and will be hanging on the cart. The top or first drawer on most crash carts is the airway drawer. This drawer contains infant, pediatric, and adult airway management equipment, including endotracheal tubes, stylets, and syringes, laryngoscopes, Miller and Mack blades. When using an endotracheal tube, please use the silicone spray located on top of the crash cart. Please spray the ET tube over the trash bin. The silicone spray will help slide the ET tube down the mannequin's throat. The second drawer is the extra airway drawer and contains mask, a nasal cannula, non-rebreather mask, suction, dual lumen stomach tubes, as well as nasal and oropharyngeal devices. The third drawer contains simulated first-line drugs including adenosine, amiodarone, atropine, calcium chloride, dextrose. To administer one of the drugs, Take a needle and syringe, draw up the proper dosage for your simulated patient, and give the medication via the IV tubing. Please verbally state the drug and dosage. Place any used needles and syringes in the sharps container. The fourth drawer is the IV supply drawer and contains catheters, needles, syringes, and adhesive tapes. The fifth drawer contains central line kits. The bottom compartment contains miscellaneous items including an emergency cricothyrotomy kit, anesthesia bag, and additional fluids. Please exercise caution when using the items from the cart around your colleagues and, most importantly, your patient. This has been an overview of the multifunctional crash cart you'll be using during your simulation exercise.
Hi, there's on these emergency syringes, there's a couple different types of syringes and how to assemble them. It's pretty simple. All of the emergency syringes come with two pieces. You have to flip the tops off just gently like that, and then you attach the two pieces together. They fit inside each other, and then you just gently do a little twist until they're attached, and then this end comes off, and it can be lure locked into a running IV site or a IV site that's in place, or you can attach a needle if you need to on the end. The other type of syringe, it has a needle already attached in that green section. There's really no need to use that. We'll still assemble them the same way. Just flip the yellow pieces off, just gently screw them together. And in this case, all you need to do to get the lure lock is to twist off the little yellow cap, and then you have your lure lock site. What happens sometimes is people just pull that off, and then there's no way to get administer that to the patient. You either have to, you can just gently, you gotta be careful. So there's a needle in there, just put that green piece back on and just detach the yellow cap. And that's one example. You'll see which gets used more commonly for low blood sugar is dextrose syringes, and it's the same. It has the green needle in there, but once again, these are just same thing, only bigger syringe. You just flip the ends off and tighten the two pieces together. You remove the yellow cap, and then that just works like a regular syringe, and it'll push the liquid up. You'll see it come out a little bit, and then administer through a running IV site or a IV site already in place. And that's how the emergency syringes work.
And that's it for this 30-minute course instruction. Now we are ready to do a high fidelity simulation on a mock code.